Hello and welcome. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for the third in a series of three CMEO snacks on hypertrophic cardiomyopathy. This CMEO snack is titled HCM, Breakthrough Treatments Targeting Novel Mechanisms. CME Outfitters is the accredited provider for this continuing education activity. The CMEO Snack series is supported by an unrestricted educational grant from Bristol Myers Squibb. I'm Dr. Deepak Bhatt, Executive Director of Interventional Cardiovascular Programs at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. I'm joined today by my good friend, Dr. John Spertus. Dr. Spertus is the Daniel J. Lauer Missouri Endowed Chair and Professor of Medicine at the University of Missouri, Kansas City, and Clinical Director of Outcomes Research at the Mid-America Heart Institute in Kansas City, Missouri. Welcome, John.
Thanks for having me, Deepak.
In addition to CME CE credit, today's activity is eligible for ABIM MOC points. Once you complete the activity, provide your ABIM ID and birth date when completing the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as a CME for MIPS improvement activity. Our learning objective for this CMEO snack is to assess trial results of emerging HCM disease-specific treatment targeting cardiac myosin to address the underlying molecular defect of HCM. John, could you go ahead and please start us by providing some background on why there is a need for novel treatments for HCM?
HCM is actually the most common genetic heart disease with a very wide heterogeneity of clinical and phenotypic presentations. It's estimated worldwide that about 1 in 200 people have HCM and that it's equally distributed by gender, race, and ethnicity. It turns out it's actually the most common cause of sudden death in the young, but many patients are really free or don't even realize they have this disease until they start either developing symptoms or have a cardiac event. And over the course of time, about 1 in 5 patients will develop atrial fibrillation. And as this graphic shows, it's estimated that about 90% of patients that really have HCM are unidentified. About 6% are symptomatic and about 4% asymptomatic. HCM is primarily a myocardial disorder with unexplained left ventricular hypertrophy that is often caused by genetic variants of the sarcomere. Our current treatment per the guidelines is really to focus on symptom control, genetic and family screening, and to risk stratify patients to seek to prevent sudden cardiac death. The mainstays of medical therapy are beta blockers, non-dihydropyridine calcium channel blockers, and disopyramide that all have negative inotropic properties. And when those fail, patients are then referred for invasive options, including surgical myectomy or percutaneous alcohol septal ablation.
Well, those are really great points about HCM, and maybe one of the newest pieces of data out there is just a huge role that genetics plays in HCM. Well, as it turns out, we've got a novel mechanism of action in the emerging agent mavacamten. How exactly does mavacamten work?
So mavacamten is a novel drug. It's a direct cardiac myosin inhibitor. And so in HCM, where there is sort of excess hypercontractility, blocking the actin-myosin cross bridges and decreasing contractility may directly influence the pathophysiology that causes symptoms in this condition.
Now, Explore HCM was the phase 3 trial for mavacamten that established efficacy and safety. At the American College of Cardiology, just the recent sessions in 2021, you in fact had presented some data, really spectacular data that looked at quantifying patients' health status in the trial, and those data have been published in The Lancet as well relatively recently. Can you tell us about the basis of your research and the role of patient-reported outcomes here and in general?
Yeah, absolutely. Thank you for asking. I've devoted my career to trying to improve the patient-centeredness of care. And the first sort of facet of that is trying to understand how heart disease impacts patients, their symptoms, function, and quality of life. And one of my earlier contributions was developing something called the Kansas City Cardiomyopathy Questionnaire. And this is a 12 or 23 item questionnaire that really asks patients in the same way that an experienced clinician would when talking to a patient in clinic, how is your disease affecting you? How bad are your symptoms, your physical function, how it interferes with your social functioning and your quality of life? And these domains of the KCCQ can be summarized either into a clinical summary scale, which seeks to replicate the New York Heart Association by focusing on symptoms and physical activity, or an overall summary scale, which seeks to quantify the totality of the way a disease impacts patients, their symptoms, their physical and social functioning, and their quality of life. Scores range from 0 to 100, where higher scores mean fewer symptoms, better function, and better quality of life. And we've done a lot of work to figure out on this sort of 100-point scale, how big of a change is clinically important. And it turns out a 5-point change is a small but clinically important difference from both patients and providers' perspective. And a 10 and 20-point changes are moderate to large and large to very large clinical changes. And while the KCCQ was developed for heart failure at large, before doing the Explorer trial, it was a lot of cognitive interviews were done with patients to confirm that the KCCQ was relevant to them and that they understood it. And so that is sort of how we seek to quantify the health status of patients. So in the Explorer trial, we sought to understand the benefit of treatment over time in patients with mavacamten versus placebo. And so this was done by describing the changes in KCCQ scores at baseline and over 30 weeks of observation. And then we compared directly the 30-week change in scores by a mixed model repeated measures analysis that took into account the different characteristics of block randomization. And then to support the clinical interpretability of these findings, we also did a responder analysis where we looked at the proportion of patients who got worse, indicated by a score that was lower at 30 weeks by 5 or more points than at baseline, those who were unchanged, those who had a small improvement of 5 to 10 points, those with a moderate to large improvement of 10 to 20, and those with a large to very large improvement of more than 20 points on the KCCQ overall summary score. Well, as this graphic shows, the change over time was much greater in blue in the mavacamten treated patients than in gray, the placebo treated patients. And while the placebo patients did get a little bit better over time, by 30 weeks, there was a 9-point difference in the KCCQ overall summary scale. This is amongst the largest changes that I've ever seen from a drug therapy, rivaled only by tafamidis in amyloid heart disease. But in that condition, patients got worse on placebo and they maintained their health status on active treatment. In this case, the health status of the patients markedly improved from within 6 weeks of being treated and sustained out to 30 weeks. And what was very interesting about this study is that they reassessed the health status after they stopped therapy. And what you see is that in the mavacamten treated patients, the benefits that they got from taking the therapy rapidly dissipated, whereas they didn't change the control. And at the end of 38 weeks, when neither group was on medicine, there was no difference between the treated and control patients. And while there have been very impressive improvements in the KCCQ with structural heart disease interventions, for example, we can never remove the MitraClip or the TAVR to see what happens when you stop therapy. Here, once we stop therapy, the benefits immediately dissipated, which really provides more evidence of the direct benefit of myosin inhibition on the health status of these patients.
Yeah, that's an important point. So I know your answer here, of course, but just for our audience, were these changes then clinically meaningful?
Yeah, they were, and to sort of really bring this home, we did a responder analysis that I talked about earlier, and we looked at the proportion of patients who got worse, didn't change, got a small, a moderate, or a very great deal better over time. And you see that in blue in the mavacamten group and in gray in the placebo group. And what's impressive is that, you know, among the patients who got worse over the course of the study, almost 1 in 4 versus 1 in 10 of mavacamten treated patients got clinically worse over the 30 weeks of observation, meaning that for every 7 patients treated with mavacamten, 1 did not get worse as compared with placebo. Even more impressively is that if you look at those who had a 20 or greater point improvement, and this is a huge improvement in patients' symptoms, function, quality of life, over a third of the patients treated with mavacamten versus 15% of patients treated with placebo got a whole lot better, meaning that for every 5 patients you treat, 1 will be substantially better with therapy than without.
Yeah, that's a really low number needed to treat. So, John, what were the overall takeaways then from the trial?
Well, I think mavacamten is associated with substantial health status improvements in patients with symptomatic obstructive hypertrophic cardiomyopathy, with a very small, as you said, number needed to treat for a very large improvement of about 5. These benefits were seen early after treatment, but regressed when the treatment was stopped. And I think this really illuminates the benefit to patients and can guide us in discussing this treatment option with them when they're symptomatic with their obstructive hypertrophic cardiomyopathy.
Yeah, no, those are really wonderful points. So, in terms of new agents on the horizon for HCM, anything we should be keeping an eye out for?
Yes, there are some new studies ongoing to treat HCM, including the Redwood study, which is another cardiac myosin inhibitor, Improve HCM, which is in early phase 2 clinical trial, and another phase 2 trial of a novel class of antiarrhythmic and late sodium channel inhibitors to see their impact on the symptoms and outcomes of HCM.
Well, thanks, John. This has been a great discussion. Let's go ahead and summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what we hope that our audience will take away from this presentation to apply to practice. First, to apply the etiology of HCM to novel mechanisms of action for the management of HCM, to use validated tools, for example, the KCCQ, to help quantify treatment benefits, both in trials, but also in clinical care from the patient's perspective. And finally, to evaluate patient-reported outcomes as part of the overall clinical benefits of emerging therapies. As I mentioned, this is the third in a 3-part CMEO Snack series on HCM. If you haven't already, please visit the Cardiology Education Hub on www.cmeoutfitters.com to participate in Part 1 and Part 2. Don't forget to complete the evaluation and collect your credit for today's activity. You'll be able to print your certificate from the platform. It's been a long time since there have been new therapies for HCM. Thank you, John, for joining me today to share your data about mavacamten. And thank you to the audience. I hope our discussion gave you new insights about the future of treatment for patients with HCM. Thank you.